by Professor Dekkers and Koster. The lecture is called Pathology and the word I cannot pronounce. Maybe
PETthology.
PETthology.
It's also Professor Liu not at all. So.
This answers my question because I wondered which of you two invented that word, but okay.
Okay, thank you very much. Thank you very much for the invitation to speak here today. We would like to speak about the pathology and the pathology of thyroid nodules, and in specific, what to do if you have first we have a PET and then a nodule, or if we have a nodule first and then the PET. No disclosures. And the content of today's presentation, my part will give a brief introduction about thyroid nodules, their pathology and their diagnostics. So, on thyroid nodules. The prevalence of palpable thyroid nodules lies between 3 and 8%. But if we look at imaging and autopsy studies, we find prevalences up to 68%. And only approximately 5% or less of those harbors a malignancy. Standard diagnostic work of these nodules is done by ultrasound and then performing fine needle aspiration, or FNA. Looking at thyroid carcinoma in the Netherlands, the incidence lies between 2 and 4.5 cases per 100,000 persons per year. 80 to 85% of which are the differentiated subtypes, so the papillary and the follicular carcinoma, in a rate of 4 to 1 approximately. If you look at the cytology that is obtained from thyroid nodules, it's classified using the Bethesda system, which uses classes from 1 to 6. On the one end of the spectrum, you have your malignancies, and on the other end, the benign. The benign and the malignant ones, they make up about 75% of all the FNAs that you perform, and those are the ones that are easy to diagnose, or relatively easy. In between lie the more difficult categories. Your Bethesda 3, your Bethesda 4, or your inconclusive or indeterminate thyroid nodules. These are the nodules that contain follicular patterns, atypia, and it is said that the overall malignancy rate, if you combine these categories, is approximately 25%. Because the malignancy rate is approximately 25%, all these individuals will in the end undergo diagnostic thyroid lobectomy, which is an invasive procedure and is performed for a benign nodule in 75%. So what you would really like is to have an additional diagnostic to further differentiate these nodules and maybe prevent surgery for some of the benign cases. And of course, this is how I come to PET. In specific FDG PET, we know that if the PET is negative, that almost certain the nodule is benign. Or different, a meta-analysis of previously conducted studies showed a negative predictive value of 96% for FDG PET in these nodules, with a negative test or a useful result in 1 in 3 patients. So you could prevent diagnostic surgery in 1 in 3 patients and reduce the number of surgeries performed for the benign cases from 73 to approximately 40%. Subsequent study from the same group, which was performed also by Dennis Vriends, who's also present here, also showed that this approach was theoretically cost-effective over other additional diagnostics. And then we talk mainly about the molecular techniques that are also really popular at this moment. My main research project, as many of you know, is the EFFECT study, which is a prospective randomized controlled trial that aims to validate the efficacy of FDG PET in indeterminate thyroid nodules in a large prospective Dutch cohort, and also investigate its cost-effectiveness, quality of life of these patients, and to see if the tumor genetics are somehow related to PET positivity or not. This is a study that's Professor Liu is the lead investigator of this project, and LUMC also participates. It's one of the 15 participating centers. So we know, okay, PET can be used for the indeterminate nodules, but how about the other cytology? Can we also use it in that? I wanted to briefly mention the Bethesda 1 category, which I just skipped. It's the non-diagnostic category, and it's a very heterogeneous group, but still PET, FDG PET, is occasionally performed in this group, although there's very little evidence that it works. There's only one study, performed in 2011, a prospective study that included 88 patients and found that PET had a sensitivity also in this group of 100%. Or a negative PET again showed a benign nodule. But it's only one study, and as I said, Bethesda 1 is very heterogeneous. There's a lot of interinstitutional variations in the composition of these groups, and therefore it is really hard to say whether you can use these results to use them in your own clinic without knowing what your Bethesda 1 group consists of. And I think that's why there's not a lot of research done, and I don't think that PET could be really plausible in the Bethesda 1 group if you don't know how it performs in your own hospital. The other part of our presentation, we cannot mention how PET performs in Bethesda 3 and 4 nodules without also mentioning it the other way around. We know that of the incidentalloma that are found on PET, many of them are in the thyroid. The prevalence of PET-positive thyroid incidentalloma is roughly 2%, 20% of which is malignant. And we also know that in these incidentalloma, a more intense FDG uptake more often relates to thyroid malignancy, and is also, if it's a malignancy, associated with persistent or progressive disease. If you find a PET incidentalloma, standard workup is first to find out if it's not a hyperfunctioning nodule, because then you're done. You don't have to do further diagnostics. And if the TSH is normal, you do an ultrasound and also fine needle aspiration afterwards. We know on ultrasound, other than in thyroid nodules in general, a non-suspicious ultrasound pattern in a PET incidentalloma is not distinctive for a benign nodule. So you do have to do an FNA if the nodule is larger than 1 centimeter. And then if we look at the cytology of a PET-positive incidentalloma and how it is related to its risk of malignancy, we see that there are only retrospective studies. There are a lot of studies using thyroid PET incidentalloma, but they're only retrospective. And in those studies, you see that cytology or histology is not obtained in 63% of the PET incidentalloma, which I thought was rather a lot. We also see that if histology is obtained, 20% is malignant. So that's where the 20% malignancy rate comes from. Also, if they find a benign cytology, it is often considered benign. And they usually don't perform any histology. The only study that I found was published in Endocrine in 2015, and it shows here, it's also a retrospective study, and it shows the rate of malignancies and benign nodules, and they also differentiate the Bethesda categories. And what you see here is that although it's only a small cohort, of course, you see that if the nodule was cytologically benign, histologically it was also benign. And also the malignancy rates of the, more importantly, indeterminate categories, it also approximately is the same, if you could say that for so little patients, as you would see in a Bethesda categorization in general, for the general population of thyroid nodules. So a risk of approximately 10% and a risk of 1 to 6. So what can we conclude about the PET incidentalloma? We're not really sure if they have similar risks of malignancy, because there are just very little studies that correlate the cytology to the histology of the incidentalloma. But in practice, a benign cytology overrules the previous PET-positive result, and this nodule can be considered benign. This is what I had to say, and I would like to give the stage to Professor Dekkers.
Sorry, because I have some bad news, and that's probably not a good idea on such a nice day as this, but let me start with the bad news up front. I think that it's not about PET scanning. I think everything is about probabilities. Probably even in life you can express everything, every decision in life in terms of probability. Even if you want to get married, you can do that and take the risk of a divorce of 30%. Might be not that romantic. I want to argue that many things that we see when we do the interpretation of PET scanning, which I can't, and that's the reason why you are there, you can do that, that you have to deal with a lot of thinking, at least, about probabilities. And in the previous speaker and also the presentation from Lenka highlighted that you need a lot of knowledge about these probabilities. So there we go. I basically want to make 2 points. The first is very simple. Is the test valid? And I will restrict myself to thyroid nodules because I think this is a difficult field for many reasons. But the second point I think is very often overlooked. Even if the test is valid, do we know that if we perform a test that we actually come up with a benefit for the patient? Because that's, leaving aside the research, but that's where we are doing our PET scanning to improve health outcomes in our patients. So this is the point, and as Linka already said, what PET imaging, and I think other imagings as well, they provide us a picture of reality, and every picture of reality is in need of an interpretation. And this interpretation can be correct, it relates to reality, it gives the correct interpretation of the reality, or it can be false. And these all have to do with probabilities. Oh, sorry. This is a study that's already quoted by the previous speaker, and it nicely shows the probabilities of false positive, false negative results in thyroid nodules. And for those of you who haven't worked with thyroid nodules, that's a problem because approximately 50% of people out there, also if I would do an ultrasound here, in 50% of people I just find one or more of these thyroid nodules. So how good is the PET for these nodules? Well, there we go. The sensitivity, the pooled sensitivity is very good. It might be close to 100%, meaning that if there is a malignancy, that it's very likely that the PET is positive. But this is probably more disturbing, that if for some reason a PET is performed, and hopefully it is because there's some reason to think of thyroid carcinoma, then you see that approximately 50% of the patients without a thyroid malignancy have a positive test, a positive PET-CT. So high sensitivity, almost 100%, and a specificity that is close to 50-50. You can even flip a coin. So what does that mean for clinical practice? Low probability of a false negative result, but a high probability of a false positive result, meaning if you're interested in cancer. What that means depends on the population you're doing your test on. And this you can regard as a general population, and we have here all people with low suspicion of a thyroid carcinoma. You can think of all the people that are out there with thyroid nodule, or probably 2 thyroid nodules. I might even think of you, and my guess is that if I do an ultrasound, that 50% of you will have a thyroid nodule. So low suspicion of thyroid carcinoma, then you have the people with an intermediate suspicion of a thyroid carcinoma, and then we have the people with a high suspicion. Now, where should we apply our PET scanning? And let's start with a PET scanning in people with a high probability of a thyroid carcinoma. Then PET scanning might be extremely helpful because we know that if it's negative, it's very certain that it's no thyroid carcinoma. But if we now go to a more broader population, so we do a scan in almost everyone, then we will end up with a lot of false positive results, and this number of people is huge. And what we now see for CTs, for example, if you turn 50, you get a CT scan for your birthday to get a check whether you're healthy or not. If that will be the case for PET-CT, you can see the problems and the risks we're running in, because all these people will come to my department, probably to the department of the endocrinologist, with the question, can I be sure that it's no malignancy? So hopefully the PET will be for patient care and not for general screening purposes when you turn 50 or 60 or another nice birthday number. Here's another nice graph, because this shows you, here is the sensitivity plotted, and the sensitivity, and here's the specificity, and it's plotted against the size of the nodule, the thyroid nodule. And what we normally believe is that if you have sensitivity of any imaging technique, then the sensitivity or specificity is stable over the baseline risk of a population, and that's not true. You can see that if you come to a larger nodule, that the specificity here is decreasing, but if you have a very small nodule, you can even see that the sensitivity decreases. So that means that sensitivity and specificity depends on baseline risk of the population. So the first point, I think, if you do imaging in thyroid nodules, you have to know exactly what you're doing, also in terms of probabilities. And now I come to the second part of the talk, and that's about trials. So if there's a new drug out there, and if some resident proposes a new drug for diabetes, then directly someone says, well, what is the trial saying? So it's a kind of Pavlov reaction. If we want to treat someone, we want to know what the trial is saying. And sometimes there is no trial and we have to make a clinical decision. But interestingly, the same point is not made for imaging. So if there's a new imaging technique, it's hardly that someone says, well, is there a trial showing that in the end the patient benefits from being scanned by whatever technique? Why is it important to do some randomized trials, not only for drugs, but also for imaging techniques? And I think in this respect, I really like the effects trial, which is really a randomized trial for a diagnostic procedure. Why should we do randomized trial? Well, let's first think closely on how. It's just that you randomize people between being scanned and not being scanned, everything else being approximately the same. Why should we randomize? Why should we search for randomized answers? Well, because doing a scan can have side effects. Think about a patient that has to come back for a new scan because some PET positive lesion came up with some uncertainty. So there's a potential psychological burden for every scan that you're doing. There is a financial burden, that's clear, every scan costs money. And there's also some disease burden, probably, if you have a disease and it turns out to be a false positive result, you have treated the patient without any gain. The other thing is, and that's difficult to explain to doctors, I'm doing a lot of writing on guidelines, and I always have to convince doctors that finding a disease is not always beneficial for the patient, and I think this is especially true for thyroid nodules. I hope after this talk that you're not going in the break for an ultrasound to see whether you have a thyroid nodule. There are some conditions which we should suppress our idea that finding diseases is a good idea. So finding a disease is not equal to decreasing morbidity and even mortality. And here's a very nice example. It's not from the field of nuclear medicine, but this is a trial on a diagnostic procedure. There is a genotype that influences your ENR, and potentially it influences how you dose your anticoagulation therapy. And people are randomized between having measured this genotype and not having measured this genotype. And it turned out that knowing the genotype did not improve patients' outcome. So that does mean you don't have to test for this genotype, and it was nicely shown in a randomized controlled trial. And as said, I started to say that probably in the field of thyroid nodules, this is really an issue, and that can be seen from this slide, and this is the last slide that I want to show to you before we come to the concluding remarks. What you see here on the bottom is the mortality from thyroid cancer. It's absolutely stable. Not an increase, not a decrease. But in the same slide, you see the increase in the incidence in thyroid carcinomas, and it has to do with here fine needle aspiration, CT and MR, ultrasound guided therapies or ultrasound-guided diagnostics, and probably PET will come in as well. You see a large increase in the incidence of thyroid carcinoma, and given that we do nothing on mortality, that the mortality from this disease is not increasing, not even decreasing, this shows that there's a lot of overdiagnosis. And I hope that Dennis and Liu Fei will, and Lisanna as well, will do some more research into this field to prevent people from being treated for thyroid cancer, because here personalized medicine, I think, hopefully will do a good job in the near future. So, to conclude, I started with some bad news, but I know that people from the Department of Nuclear Medicine and Radiology are really good in thinking in terms of probabilities. So the probabilities are in good hands here, and I think the second point is that we should aim for more randomized trials for diagnostic procedures.